Okay. Well, thank you all for coming back after the coffee break. I hope you're feeling caffeined, refreshed, ready to go again. And welcome to the second session, which is on use cases and data availability. We've got 4 fantastic and diverse speakers all going to come and each give a kind of short presentation, introduce themselves, give a short presentation, and then we're going to reconvene on the stage after the presentation so that we can open the floor again for discussion and questions, because I think that was a really useful part of the previous session. So the first speaker, I'd like to invite Yanwu Xu from Baidu. Yanwu.
Thank you for the invitation. Asked me to join the focus group and sharing what we have do in Baidu on AI healthcare. So before we start the main part of the talk, I would like to introduce myself. Actually, before I joined Baidu, I mainly worked on the academic research. I worked in Singapore for nearly 8 years in the university and research institute, and I'm very active in medical research area, medical imaging research area. So I've been area chair in the top conference, MICAI, and Associated of Medical Imaging. So my talk mainly has 2 parts. The first part is the AI products we have developed in Baidu and the practice on healthcare. Here is the motivation. So I think healthcare is not a complicated problem only to Chinese. I think it's a common problem because of the aging. The aging become more and more serious. So the shortage of doctor is the main problem. Once the supply cannot meet the requirements, there will be problem. So it's more serious in China because every year many medical school students change their career after graduating because the salary and income problem. It's very realistic problem, but yeah, it's more serious in developing countries. And the imbalance of the patients and the medical resource is quite common in China. Most of the top medical resource are in the big cities, and most patients are in the rural areas. From the statistics, we can see that in cities, per 1,000 people have 3.5 doctors, versus 1.2 in the rural areas. So we need to have more doctors or or we use technology to solve this problem. So Baidu as an AI company, how do Baidu can help patients in primary hospitals, I mean in the community and the poor areas, to get better health care? Baidu is known as an internet company, but from last year, we call ourselves an AI company. So we are holding the very powerful weapon called AI. So we plan to use AI to help the government and the patient to change the medical situation in China. So it's the basic structure of Baidu AI structure. From the infrastructure, the most foundation part to the platform part, we have several layers and we have a lot of abilities. So from 2013, I think, we are starting to open these AI ability to public. In this year's Baidu Develop Conference, we opened 130 plus AI technology to the public. And up to date, I think now the number changed to 150. So we have a lot of AI abilities from the basic framework to the overall solutions. So now we have the Baidu Brain version 3. So it's mainly focused on the deep semantic understanding of multimodality information. And it has 5 major keywords here. So I won't expand this too much because you are focused on AI health part. So take visual semantic understanding as example. The key technology is to detect the objects and capture the behavior and the relationship and recognize what's happening from time domain and temporal domain. So we formed this brand called Artificial Intelligence Innovation Business, and we also call ourselves Baidu Health. So this department is focusing on using AI to improve the healthcare in China. So there are 3 keywords. The first is evidence-based. We want our algorithm can be interpretable. So not only the clinicians can understand and also the patients can understand why this decision is given. The second part is second keyword is empowerment. We don't want to change the current status of the industry structure. We don't want to do the same things with our partners. We hope this is a win-win situation. We want to use our AI ability to empower these traditional industry partners. The third, last one is our target is the primary care. That means mostly basic and poor areas. So this is a brief introduction about the products we have for healthcare, which covers the whole medical process from the before diagnosis and during diagnosis and after diagnosis. Currently, we only have these 3 products available. Actually, not on the market because it's under the supervision of CFDA, similar to FDA. So we don't have the certificates. So currently, it was packed under the clinical research. So I will introduce these 3 parts. The first is intelligent triage, and the second one is clinical decision support system, and the last one is imaging part, the Fundus imaging, Fundus screening machine. For the first part, I think the main function is to match the patients and the clinicians correctly. So the patients can get health treatment in a short time, won't be delayed, and the hospitals can get the patients, receive the patients accurately, won't make mistakes, and with the doctor resource. Here's a demo. I think it's in Chinese, so I just skip it. Okay. So it's our practice on the very popular platform in China. It's called WeChat. It's intelligent triage and the patient registration platform, and used in Peking University International Hospital. For the second part is clinical decision system, decision support system. This is to learn the experience of the previous diagnosis or from the papers, I mean the evidence, and to empower the primary health care to let them to avoid make wrong decision and avoid use the wrong drugs. So this will benefit both the physicians in community hospitals and the patients, and also for the overall society to reduce the cost. This is also a short video to introduce this part. It's it's in a cartoon style, but I think you may not able to understand the Chinese. Sorry. So I just skip it. Okay. Yeah. This is a whole framework of our CDSS system, and this is illustration of the knowledge graph, which is the engine of this technology. But this technology is widely used in internet searching, so we have sufficient technology for this. So this last part is my main focus, is the AI Fundus screening machine. Here is another short video, which is from the IAPB website, to introduce why we need to focus more on the eye problems. So I also skipped this video for the time reason. In this video, it revealed that we need to focus on 4 eye disease. The first one is cataract, but which can be easily cured. So we just skip that part. So we focus on the other three major eye diseases: the glaucoma, age-related macular degeneration, and diabetic retinopathy. So our first generation AI Fundus screening machine covers these 3 major eye diseases. So it's the motivation, which is very similar to previous ones. That means the ophthalmologists cannot meet the requirements from the patients. So we need to use AI to help them. Sorry? Okay. Okay, so our technical architecture from the data level to device level is shown here. Everyone knows for AI technology it's data-driven. If we don't have solid data, which means well-annotated data, we cannot train a good model and cannot have the high accuracy. So yeah, so as I explained earlier, we call our technology evidence-based AI. So we built the domain knowledge-based, we built the algorithm architecture based on domain knowledge, so it can be explainable. To better help the operators in the remote areas who don't be well trained to operate these machines. So we embed this algorithm into these machines. So it can be, the AI diagnosis report can be output with one touch. So the report can be obtained within 10 seconds, and the accurate in terms of sensitivity and specificity is now 94% for all these 3 diseases. Here is a video show that. I think you can make it, yeah, sorry. Yes, as I showed this video because it has English subtitle, I think you can understand this. So this is our current practice on this AI Fundus screening machine. We would like to donate 500 machines to the remote areas. Now we have served more than 100K people in 20 cities. So our strategy on this machine is open and win-win. So we don't want to change the industrial situations, the existing structure. We want to benefit both ourselves and our clinical and industrial partners. So we have built this search ecosystem. Similarly, we can also build our AI ecosystem. So the second part of this talk is eye challenge, which is more related to the benchmark part. Actually, because you see that I focus on research part more. So I organized this challenge platform together with the top eye hospitals in China and Medical University of Vienna and my previous colleague in Singapore. We do this platform. Now the platform is changed to Baidu. It's hosted by Baidu for better funding support and better organization. Now we have organized 4 challenges. The first one is on glaucoma. The second one is on macular degeneration. And the third one is on pathological myopia. And this one is on anterior chamber OS, anterior segment ASOCT means the OCT screening of OCT imaging of the front part of eye, and we also organize on-site challenges. This is online. That means this is more like data sharing. You can download the data and upload your result and automatically evaluate on the website, and you can see the leaderboard. Each IP can upload twice every day. And for this, on-site challenge is usually co-organized with the top medical imaging conference, such like MICAI and ISPI. Every year we have 2 on-site challenges, and the participants are requested to participate the challenge on-site to submit the result and receive the awards. And they also need to report their technologies in terms of academic paper or technical report. And we also have challenge review paper submitted to top medical research journals. So here's our schedule. This year, we are going to have the PALM, which for pathological myopia, together with ISPI, which is held in Vienna in April. And this is called AGE, is for anterior segment OCT, which is joint hosted with MICAI 2019 in Shenzhen, China. Here is the website. It's a challenge website. Here are the 3 ongoing challenges, and this is the original participation information from the Grand Challenge platform. Now we are transferred to Baidu platform for better organization. And also for the on-site challenge, now we provide computing power. That means you just run your code on our cloud. Okay, that's all. Thank you.
Jan-Ru, thanks. That's fantastic. And I'm sorry to hurry you through the last part of your talk, because I'm sure we could have listened to that for much longer. But we're going to go through to the other presentations. I've also got so many questions for you after that impressive presentation, but I'm going to hold on to them so that we can ask everyone together at the end. So the next speaker is Weihong Huang from the China Mobile Joint Laboratory. Weihong, welcome.
Good morning, everyone. Thanks for chairman for inviting me here and then give me the opportunity to share our ideas and our practices in AI for healthcare. First of all, introduce myself briefly. My name is Weihong Huang, and my English name could be called Wayne. You guys can call me that because I worked in England for about 12 years. And then I spent 1 year as postdoctor in Lyon as well, not far away. So I am a computer scientist. Most importantly, probably people like me with overseas academic background and then professional computing experts. It's quite rare. As far as I know, I'm the only one works in Chinese hospitals like me. So I could be the best bridge between the doctors and the IT specialists like the previous speaker. So let me get on to the topic anyway. So let's do this. The topic of today is Internet plus AI, dermatology care. It's a case of skin disease, smart care in China. And then I'm coming from the Shanya Hospital of Central South University of China. And I will probably introduce my hospital later on in the slides. First of all, it's about some kind of background on AI healthcare. On dermatology, Nature has its, advanced publication in 2017, and Nature Medicine has got 9 papers on AI in healthcare just recently, probably just 1 week ago. So, which really drove us a little bit excited, in China, around my friend circle, really. Talking about AI and clinical practice, because in hospitals, doctors work in their ways, not really like the scientists do. The most important part of the clinical practice, in my understanding, seeing that two big guys or gods in our two fields, is that doctors know they have been trained for at least 15 or 16 years before they really get to make the diagnosis correctly. And then the best part of their clinical practice is not knowing what, which is computing can only do at this moment, but they know how and they know why. So there's a long way to do that, just for imitating that. And I think the ultimate way to prove whether our AI for health is useful or not is through the practice, the real practice. So the way we work in Shanyao Hospital in China, and most importantly in our field, jointly between the clinical practice and the computer scientists, is doing the 5 steps full life cycle. One is real world requirements. The second will be platform practices. The third will be available data and information. And then fourth will be proof tools and techniques. And the final one will be application and evaluation. And we will talk about benchmarking later on, but not now, not for this site. So everybody could experience some itches. That's some kind of skin disease. Actually, about 21% to 87% of the world population are affected by skin diseases. And then the biggest clinical department in the world, which is Lausanne, dermatology department of Lausanne Hospital in China, they got about 500,000 a year outpatients, which is impressive. And then in our hospital, in my hospital, they do 300,000. So which means a big group, even bigger, much bigger, demand. So priority-wise, it's very important. Skin cancer, we have over 1,000 cases a year in Shanyao Hospital, and we have high incidence and also different kind of things, like very stubborn things happening in skins. So people have this kind of priority to treat our skin diseases with dermatologists. Unfortunately, in China, we are lack of that. Highly trained, well-trained dermatologists. And then a quick study, it's not official because I did myself stats on dermatologists, US versus China. I did that on Google and then get the population and get the numbers from the official government, publications. And then you see the dermatology and one in 100,000 in the US is about 2.6, but in China it's only 1.6. So in Hunan province we got a similar population like that in the UK, 60,000, but we only have about 500 only. But our aim is to train about 5,000 in 5 to 10 years time. So that takes AI, that takes big data, that takes the internet. So we need a platform to operate. Doctors can only see the patients face to face and make the diagnosis based on the exam results. And then if we need to make the diagnosis or make the prescription, repeat prescription online in China, it has to be licensed for now. And then, because China is pushing forward about the internet plus medicine strategy at the national level, That was actually published in April 2018, which is last year. And then we have the first of its kind and dermatology internet hospital licensed in China. And then that's based on our department and based on our hospital. That's in November 2018, first of its kind. And then not only the operation platform, we need the data platform. So we have the big data platform supported by Shanghai 3 hospitals, and we have the Central South University to support us, technically. And that's actually has been addressed by the national leaders at different occasions. So we're also supported by the national key projects, so which means we aim to build up the largest skin health disease queue in China, because that's actually something from the Department of the Science and Technology, and then supported by the Ministry of Health. So, and then we have the data sets, full data sets. When we say data sets, not only about images, but also the full EHR, or limited to EMR, electronic medical data, not to say EHR outside of the hospital. So we have that data accumulation of Shanghai hospitals, which accounts to over 10,000 beds in total, which in the past 20 years, from 1990s to now. And then we have that in billions. Yeah, the data-wise. And the data sets we have is impressive because we are the first one doing the medical big data platform in China. And we have the time span over 15 years or over 10 years in different volume. And then that's actually counting to over 180 TB. And the data set coming from different sources. They have over 200 hospitals from across the country, 30 provinces, and over 50,000 patients, over 200,000 clinical images, a skin cancer database with 5,000 cases, full profile, and then etc. So we have developed a set of tools, mainly designed by ourselves and supported and by small groups from university and then the high-tech companies. And then that's in our domain. And then developed 10 standard data sets, which covers 92 subsets, including skin diseases. And then this is our, the big data standard published, and then people try to accept that in our network. And then we have the biological sample bank, so which is important for our research. And then this is a melanoma biological sample collection standard, and we try to standardize the full collection process, and then give out the specification if you want to get the image in our database, which is important because if you are talking about benchmarking, that's the starting point from the data source. And then we have the skin disease image or picture library. Talking about picture, talking about images, sometimes we have the scope, and then we have the mobile, and then mobile phones taking the different kinds of qualities of images. So we need to get that in order. So this is our current data set. And then the Shanghai Skin Disease Data Collection Platform is using the cloud computing platform. And then one of the collection source or channel is mobile smart app. And we ask them to take the right picture in the right way. And then this is called train the trainer. We don't really deal with the clients directly or the patients directly. We only deal with the doctors, even the primary care doctors at the lowest level. And as far as they can understand what we are doing, and then they can do the right picture, which is good for dermatology diagnosis. So On the skin cancer data work, we have the open platform in China, which is in that field, which is well known, and then that has been supported by the network, across the country, and then the full life cycle has been processed in this way from the primary image and the referral, the doctors doing the labeling, annotation, and then get the medical record, and then that could be remotely diagnosed, and then get the prescription, and then from the local area, and then get it back. And we even teach them how to do the right, we say, rubbering, and then getting the paste onto the skin, and then because that's important. Economically, if you get the right tool, right way to do that, it can save you money, because that's not NHS. Everything is free. In China, it's different. And then we have the SkinNet system, which is actually supported by the Central South University and then NUDT University research team. And then they are actually driven by the doctors, not by them, not by computer scientists like me. They are all driven by the doctors. And then we have the practical skin disease classification tool covering 6 common skin diseases. And then currently is in the trial process. But we can't really say it is already fully, we say, deployable. It's still a long way to go, because every time we have to get that. This is our skin network, and then academic inference. And then this is the basic coverage of our network across China. And then this is supported by our National Engineering Lab for Medical Big Data Technology. And then this is the work of summarization. And then it is now being supported, especially in our province, covering, and then the surrounded several provinces, covering about 100 million. Population, something like that. And we have the mobile learning and kind of application using the social network apps. They do the periodical or regular training over the mobile phone. Over the mobile phone. So this is the major part of my presentation. And the last words: work of AI for healthcare is always on the way. And then thanks for listening. Thank you again. Thank you.
Well, thank you, Wei Hong, for a fantastic presentation. And I think what I'm realizing after the last 2 speakers is that we need to stop worrying about the ECG interpretation coming from Harvard, and I'm going to have to learn Chinese to access the latest symptom support systems. The next speaker is Indra Joshi from the UK National Health Service. Thanks, Indra.
Hello. Hello, everyone. I always feel a bit of a lecturer standing behind the lectern, and I have an unknown habit of prancing around on stage. So, anyway, welcome. Thank you very much for inviting me. I'm Indra. By background, I'm an emergency medic, so sometimes I try and save a life in an A&E, as we call it in England. But for my sins, no, I'm joking. Not really. I work for the NHS. This is the commissioner in the UK, which is called NHS England. And if you think of it in terms of money, money comes from our Department of Health and it comes to us, and then we spread it around the country. But before I start, I'm conscious we've all been sitting. This is a health conference thing after all. So can I get everybody in the auditorium to stand up? Just stand up for me. Put your laptops down, your phones down, stop tweeting. Guys at the back, you as well, gentlemen with a mic. That's it. Now, find somebody next to you, give them a big high five, and turn around and then sit down. So you can all get your steps, and you can all say, yes, I came here, and I did something active. We can talk about AI, but we're all going to die of DBT. No, joke. So, I'm quite new to this field, so I work in NHS England. We have something called a digital transformation portfolio, where we do a whole bunch of stuff. And within it, we're about trying to create a digital ecosystem. So that goes from creating standards within EHRs. So as you know, in the UK, we have lots of EHRs. There are some big ones, there are some small ones, there are some homegrown ones. We also try and create standards for people developing things, so be they innovations, apps, wearables, whatever you want to say. And then we can do things that are, what one might say is quite boring, but actually quite fundamental. So if you want your patients to be able to use all these digital things, we have to give them the tools to do it. So we've created things, programs like Wi-Fi and login for citizens. But I'm not going to tell you about the whole portfolio, because I know I've only got 10 minutes to talk. So I'm going to talk about two things that we've done recently that's quite exciting and may be helpful here in this portfolio, this working group to talk about. So one is something called an evidence standards framework that we did. So I have two roles in the NHS England. One is to look after some standards and evidence and review of apps and wearables, and the other is this kind of global weird role of sort of the AI clinical lead. But I never know what AI really means. So let's talk about some practical stuff. So Naomi, say hi to everybody. Hi Naomi. Was quite instrumental in helping us develop this. But one of the things we found when we were reviewing the apps that came into our app stores, we have an app store for patients and citizens to have a look at. It's trusted tools, and they know that when they see the NHS brand, you know, those little white letters in a blue box, they know that it's safe and it's usable. But we found that there were varying degrees of evidence that was submitted on the back of these products. And it was quite difficult when you were reviewing them to know what was good and what wasn't good. And there was a lot of backlash from our commissioners. So commissioners is just a fancy word for people who buy stuff within the NHS. And they said, well, you know, you didn't do an RCT there, or that's just not good enough for the thing I need. So we teamed up with NICE and a bunch of other people, so Public Health England, MedCity and Digital Health London, which is an accelerator programme, which for those of you who aren't familiar with accelerator programmes, is to help innovations get into the NHS, which some of you might know is quite hard. And we developed a framework. The framework is accessible here. Here's the link for those of you who are interested. And it's being revamped because we've had a bit of feedback on it. And it'll be republished again in February, end of February. So the idea was to create a framework for what your tool was, so functional classification, and this is based on risk. So the higher you go up, the higher the number, the higher the risk of harm. And then we also put two things behind each box. So behind each box you have an evidence table like this. It's a little bit wordy. We're trying to make it a bit more interactive, but we felt let's put something out there rather than make it look really whizzy and cool. And so what's the minimum evidence standard that you need, and what's the best practice? And this goes for the three tiers of tools that you saw previously, so evidence 1, 2, and 3. And then on the back of that, we also decided to try and write an economic impact, because it's really difficult when you're doing this stuff. It's quite a skill. And what we found was there were quite a lot of developers out there that didn't always have the skill set to understand what economic impact was for their product. So, for example, they would say, okay, we're developing an app for diabetes, or we're developing an app for breast cancer, which is great. But then they would say, well, it affects every person in the world with breast cancer. You're like, well, does it? Or is it specifically for English-speaking people who happen to live in this particular area of the country, and therefore let's just hone your population sample, which is something that's a bit more realistic, that then the commissioner can actually understand and assess effectively. So we publish these, they're online. Oh, there's my prawn, let's wait for the prawn. So do have a look, do take a look. I'm aware that they're quite based on our UK population, but it's quite useful. We've had a lot of feedback from lots of companies and lots of commissioners and lots of academics around the world. And when we developed this, we didn't all sit in a dark room like this one. We went out, we did about 14 workshops with both innovators, academics. We have something called Royal Colleges, so Royal Colleges of Medicine or Psychiatry, etc., and they all came along as well. So we really tried to bring everybody with us when we developed these standards, because we were quite keen to say that they weren't just from a national standards perspective, here you go, put them out there, but actually what do you need as people on the ground doing this stuff? So that's one thing I just wanted to say, which we're quite proud of that we've done, and we put it out there. We're hopefully going to make a thing. And then what's the bigger picture? I didn't know what to put this as a connecting slide. So just a prawn, you know, why not? It's always good. So AI. And I was really, thank you for your really amazing talk. I'm afraid I'm not going to give any such detailed talk of what we're doing here in the UK in AI, but I just wanted to give a very a very brief overview of some of the stuff that's happening that we've done and some of the stuff that we're trying to do to allow the safe and effective development of AI technologies. So our Prime Minister, I haven't mentioned a B word, I'm not allowed to mention a B word. So sorry, I apologise profusely. So Theresa May, she set out in May last year 4 grand challenges. So the 4 grand challenges, you can see them on our .gov.uk website, are about saying, how can we utilise AI or AI-based technologies to help us improve society? So one is around energy, one is around mobility, one is around ageing, and the one that we're most interested in from a health point of view is around the use of data and innovation and AI in early diagnosis. So that's the one thing that sort of covers. And on the back of that, there's been a lot of hubs and collaboratives that have come out. So we've got something called digital innovation hubs, and they are pockets around the country where you can collect data sets, or data sets are merged together so that you can utilise them in a way for, I don't know, looking at, say, for example, melanoma screens, for example. And then on the back of that, we've also got a programme called LICA, which stands for Local Health and Care Record Exemplars. And again, they are about connecting health across the systems. It's not just about the EMR or EHR, it's also about your primary care records, we have GP records, and then how do you connect those GP records to social care records, and if you're in the community, to your health visitor records, etc. So you get a much more holistic view of the person at the end of that record, and how then you can infer things on that. And one of the things we were asked to do from our ministers was say, well, it's great, all of this stuff, but how do we know that it's safe? How do we know that it's been developed in an ethical way? And also, how do you know that actually it's going to do what it says it does? Because we've all been victim of, some really great marketing ploys. But what we really want to know is, is there a set of rules that we should be abiding by when we do that? So we went around the country, we went around with some of the leading academics in this space and said, what would you say were some of the rules around here? And we've come up with a list of 10 principles. Again, you can have a look at it. We are oh my God, blue on blue, it's really bad. You can tell I'm a doctor and I have no PowerPoint skills. But here, here's the link to it. We're revamping this because we've had quite a lot of feedback, and so we've changed it again. Hopefully, we'll be republishing it sort of March time, February, March time. But some of these aren't principles that are very AI at all. Some of these are just understand what your users are, understand their need, understand the context, understand GDPR. Now, a lot of people don't really understand GDPR. So what are the things within GDPR that relate to you when you're developing this, but not just developing this technology, but deploying it as well, because I think that's quite fundamental. And then the one that we got a lot of interest in was sort of number 7 and number 6, be transparent about this, especially from the NHS perspective. I understand that there are a lot of commercial organisations out there, but we are not free, the NHS, unfortunately, but we are free at the point of care. And the idea is that, if you're donating your data, be it for primary care or secondary uses of care, you always feel that you should be getting a good deal, and the NHS should be getting a good deal. So we set out these principles, and we're now working with a number of big tech companies and SMEs to say, well, how can we work through some of this, and how can we use it to affect our regulation? So the second thing we've done is we've had a look at all of our regulations. So we've got the medical device regulation, we've got a bunch of other regulations, and we have a lot of standards that we've developed as well, things like our clinical safety standards, we call them the SKY standards, which are about the clinical safety risks when you implement technology, be it on the system or the workforce around it. And so, well, where are the gaps in that regulation? What can we do to either help the regulators, or what are the regulators doing to try and close those gaps, to deal with some of this technology? Actually, when we did a review of the law, we found that actually the law is quite clear in this space, but as always, the interpretation of the law is slightly different. So some of what we're doing is actually quite a lot of guidance. But again, here is the resources that we're doing and the support that is needed to try and move this along. So like I said, we're doing some case studies, so hopefully over the next year you'll see coming out that we work with some big companies who are doing this stuff, some smaller companies. We have something called test beds, where we work with lots of people to try and say, well, how do we improve a care pathway? Because, You can do something in an isolated space. You can look at an isolated problem, but you and I both know, those of you clinicians in the room, that just doesn't make sense. How do I pay for that in a pathway, and how do I implement that into my care practice every day? So what does that mean when you actually implement it? What are the rules to the game? And also, how do you pay for some of this stuff? So this is quite a busy slide, and I appreciate it's quite busy, but it's to try and give an overview of who are the funders in the space, what's the actual problem we're trying to solve, where can our code of conduct, who are the different players, we've got some universities there, what are the outcomes we're looking at, what will be the benefits in all of this. And this is just a sort of a rough slide. It's not supposed to say this is the reality of what will happen, but this is to try and say, look, this is not a simple space. It's not about, here's one technology that's going to solve the problem of screening and breast cancer, and boom, there's your answer. But to say there are a lot of players in this space, and how do we work with all of them so that actually we can get some good outcomes for the people who matter at the end, the patients. So I talked a little bit about our digital innovation hubs and our local, we call them LICAs, because we like to put acronyms and things in the NHS, but local health and care echo exemplars, and the fact that access to data is quite fundamental, and when you've got lots of different pockets to try and create layers and standards around this can be a bit tricky, but we are working in that space. So for example, if you're in London, this is just a very, something Medicity pulled together literally over a summer. So well, look, here are all the different data sources that you have. Now how do you start unifying some of that? How do you start creating some standards around that? So that's like the technical stuff that we're doing. And then let's not forget the people in here. So we have the glorious Eric Topple, those of you who might know him. He's come over to do a review of our workforce, and hopefully the Topple review, which is focused on genomics, robotics, AI, and digital medicine, and the impacts of those different topics on the workforce. And the workforce not just being doctors and nurses, but allied health professionals and the wider workforce as well as the impact on patients. So that review is coming out later. You can kind of see the link is there with the interim report to say, well, what training is needed to start changing this workforce so they're better equipped. And then there are some things that are a bit difficult that we're starting to explore. And these are just very high-level things. So we partnered up with Imperial, so Imperial have a global health initiative, and they're looking at what are the evidence standards for applied AI in healthcare. And they're taking a set of examples. They've set up a Delphi group across the country and internationally with a bunch of their partners as well as others, and to say, how do we actually explore some of these issues? We've looked at Principle 7, and we don't really know what the answer is. If any of you do know the answers, please do come and share those with us. But how do you actually, what's the SOP if you were to deploy machine learning algorithm into a point of care solution? And then what are the regulatory changes? What do we need? So I don't know if MHRA come here, but our Medicines Health and Regulatory Authority have teamed up with NHS Digital, who host a lot of our data within England, to say, well, how do we create a sandbox environment to test some of these things? And then what's the model management that happens once we've started testing them? So yeah, so that's just a little bit of a brief overview of what we're doing, some of the standards we've created. I haven't tried to explain any of the actual technologies we've done, because that's a whole new topic. But this is just to say that we're thinking about it. We don't have all the answers, but hopefully we can learn and collaborate along the way. Thank you.
Indra, thanks very much, because I think that really gives us an idea of the complexity of the system that people commissioning care on this national level are wrestling with. Again, so many questions, but I'm going to keep going because we've got one final speaker before I invite everyone to the stage for a panel discussion. So the final speaker is Saurabh Gupta, Professor in Cardiology from the All India Institute of Medical Sciences. Saurabh, thanks very much.
Thank you. It's really been an honor for me to be here to participate in the focus group meeting. And unlike the initial two presentations and unlike NHS presentation, I'll be just giving the overview of Indian perspective, what's being done in AI space in India as of now, and what we are thinking how to handle this data privacy issues at different levels. I'm sorry about that. Okay. So as you know, India has the second largest telecommunication network in the world. 900 million Indians are expected to use mobile internet by 2025. And we have a large pool of experts in both IT as well as health sector. We have world-class facilities. An estimated 0.9 million allopathic doctors are available in India. Indian doctors have established themselves globally. But the problem is that access to quality healthcare remains an issue. And as was also spoken by my Chinese counterpart, there is only one doctor for every 1668 people. And this is the disparity of the situation we have. Most of the doctors are in the urban areas, while the need is more in the rural areas. And you can see how the providers and the requirement is split. The quality healthcare access is a major challenge which we face, and we think that is the area which can be bridged by use of artificial intelligence, in the beginning at least. And to just give an example, this is a map from one of the hospitals, a leading hospital, cancer hospital in India, Tata Memorial Hospital. And it just shows that how many patients are coming from different parts of the world, India. And this hospital lies somewhere here. And then you can see these many patients are coming from this area. These many patients are coming from this area. And people traveling more than 1,000 kilometers is not uncommon to receive that kind of treatment. And that's a problem in the current era. I'm sorry about that. Okay, and the second problem is that we are one of the economies which has one of the highest out-of-pocket expenditure for the health needs of our population. Now, as such, the quality healthcare has a problem globally, that there is exponentially increasing amount of patient data which we have, exponentially increasing super specialization of healthcare, where we tend not to communicate with our counterparts in different specialties. There are no standard policies of data keeping and data sharing, and problems of human nature, as we all know, problems of therapeutic illusion and recency bias are already inherent in the quality healthcare. What we expect when we treat our patient is the modern healthcare, we want to see somewhere close to sigma 6, but we know it's nowhere close to it, and human error in diagnosis and management is the third most common cause of death. We continue to rely on one-size-fits-all approach, and I think this is one area where AI again can help us. Now, as we understand, AI can be descriptive, predictive, and prescriptive. I think as of now, in the short term, it is the descriptive nature of the AI which is going to help us guide forward to deliver healthcare to the masses. Now, health professionals are anxious, as they are everywhere else. In India, we are anxious as to if AI is going to replace. So, we think we should aim for the AI assisting the doctors, improving their capabilities in diagnosis and managing, and enable them for early detection and treatment and delivering it to the people who are not yet receiving quality healthcare. Now, as I've already mentioned, large pool of experts is already available, and as we know, a large amount of population which we have in Indian subcontinent, AI adopted and applicable in India will be directly applicable to 40% of the world's population, and that makes it very, very interesting and useful. As we were just discussing in the previous talks, ethnicity applicability remains an issue if you are talking about AI algorithms. And if you develop a tool and ethnicity which has a larger population, you are likely to apply it to a larger population globally. And an environment of innovations has prompted many startups to join the AI landscape in the current scenario. Now, focus areas I have already mentioned: bridging the problems of access to quality healthcare, providing preventive healthcare and early diagnostics, and we are focusing on standardization of data collection and maintenance. Now, AI for healthcare in last few years, I think, is a story in making, which is going to be successful in years to come. Both public and the private sectors have joined hands, both academics as well as the private sector companies. Experts from all sectors are coming together to make best use of AI. I'm a cardiologist myself. I'm a hardcore clinician. I'm a clinician for last 15 years, and in cardiology, I'm practicing for 12 years. And I know the problems which we face in a clinical scenario. I keep interacting with engineers, and as was mentioned by, I think, Indra, that sometimes our engineer colleagues are working on areas which may not be having clinical use. So I personally was motivated to pitch in this effort if some of those efforts can be directed to a correct challenge which we face in the clinical scenario, and not to waste our talent which we have in the IT side. Now, Government of India has taken a lot of initiatives right from 2015. As you can see here, we have E-Health Authority, and a Niti Aayog has made a artificial intelligence task force in 2017, which is coming up in a big way to guide and lead the artificial intelligence development and deployment all over India. Now, as I already said, that data is a problem when we data is the source of AI, and data handling is a problem when you deploy AI. So we are making a new IPR policy under the theme Creative India, Innovative India, and we expect that this is going to solve some of the problems which we may have regarding data handling. Indian hospitals have taken leads with multinational companies to work on that, and a lot of innovations has gone. As a result, we are having ongoing Digital India program, Atal Innovation Program, and multitudes of funding agencies which are supporting especially the AI startups in India. Now, some of the examples like Cure AI, this gives answers to a major public health problem of tuberculosis in developing world. And this company talks about digital detection of tuberculosis and many other similar lesions by X-ray, and they have worked on almost like 1.2 million data sets to bring about their validation. Something similar, which was published in Lancet in October, on detection of neuro abnormalities on CT, something on quantitation of MRI and CT. These are all work which are going on right now, and we have our chatbots in the field of mental health. We know mental health is a problem which is growing very fast, and these kind of chatbots are trying to overcome the problem, the hesitancy a patient may have to talk to their physician because of the social taboo which we may be there, more so in the developing world. The AI landscape has further promoted innovators to use newer techniques like thermal imaging for early detection of breast cancer. And this is one of the Nearamai startup which is working on this to detect breast cancer earlier. And there are many more tools for retina imaging, and there are at least 50 more similar companies which are working. Government sector is not behind. ICMR, which is the leading research agency in India, is working on antimicrobial resistance surveillance network and has deployed AI for detection and anticipating resistance development in different microorganisms using their genomic data sets. And as if you see this from India has fourth number of AI companies. Academia is not behind. We have new tools, new courses for promotion of AI, including postdoc fellowships for doctors to bring and become part of artificial intelligence sector. Scientific research, again, we are working on well. Data management, as I have already mentioned, data is the smallest and probably the most important unit of AI ecosystem. And we have a large pool of digital record of population which can be used. And to bring about the data, bring about all the sectors together, the IT sector, the health sector, different ministries. The Government of India has come up with a program called AI Research, Analytics and Knowledge Assimilation Platform, and we look after everything and supervise everything. Some other proposed areas, maybe since I'm a cardiologist, I thought that I'll do justice to this if I say. So this is one of the rhythm which can be either life-threatening or it can be a benign supraventricular tachycardia, and look at the algorithm which is so complex. Now, if you go on doing this in emergency, you may waste crucial 3, 4, 5 minutes. And here is the one where we can use artificial intelligence to guide the medical doctors to take that decision. Another area can be enhanced 3D visualization of current generation of CT scans. Right now, we are dependent on 3D printing, which will occupy a lot of space, which is a kind of a concern, which I personally have. And if we can use AI or similar tools to develop something like enhanced 3D visualization, then that can be directly deployed for patient management. So to summarize, AI provides once in a lifetime opportunity for all of us to bring change. Indian public and private sector is committed to develop accurate, creditable, responsible, and preferably explainable AI for health. AI validated in India is directly applicable to nearly half of the world, and that's bring the strength of Indian scenario. In nutshell, India is ready, willing, and able to develop and deploy AI for health. Thank you so much for patience hearing.
Saurav, thank you so much for a fantastic presentation. I'd like to invite all of our speakers back to the stage so you can ask some questions. In the meantime, I'd just like to thank you again for fantastic, diverse and fascinating presentations. Well, I'm definitely tempted to use my advantage as the chair of the meeting to ask the first question, and I can do, but is there anyone from the floor who'd like to get in before me? Yes. Pipped.
Great, thank you. Fantastic presentations, everyone. So my question is actually was based on the last meeting that we had and presented a solution on early detection of diabetic retinopathy. And one of the questions we got from the audience, the panel got was, all this is great, AI can help in early detection and diagnosing diseases. But what happens when you won't actually solve the problem in terms of giving a solution, in terms of actually administering healthcare to the people at risk? So the gentleman pointed out that in a lot of cases in resource areas which don't have the resources, this creates an additional problem because now you've identified people at risk, but you don't have a way of actually delivering healthcare to them. And we didn't have a good answer for that. And I think the only answer I could come up with was that the early detection helps because the earlier the detection is, the lower cost the intervention is. But, there are people here from the healthcare sector, so I thought this question is better addressed or, answered by them. If there are any solutions to that, that'll be great.
Okay, so great question. How do you handle a situation where you're working in a system where AI can diagnose or predict or classify something, but which the system doesn't have the resources to treat? I can see, Saurav, that you're itching to get in first.
Yeah. I think we are going back to the same question of getting the lead time when you diagnose something early and then treat it. So any screening tool has efficacy and usefulness if you can treat that. So it is up to the governmental agencies to develop that hierarchical system of referral for these kind of areas which doesn't have access to healthcare, to bring them to the areas where they can be treated. So AI tools alone are not going to work. There has to be strategy for bringing that uncovered areas to the mainstream healthcare.
Indra, I can see you nodding.
No, I don't think this is working. Oh no, it is. I agree with that. I think what I try to say is it's not about just AI has become a huge buzzword. So yeah, let's get early diagnosis and let's see whether or not it solves the problem. So we have an initiative in England which is about getting a cohort of 5 million people to help us with, it's a healthy population on early diagnosis. But it still doesn't answer the problem. And we had a test case last year where we tried to identify patients in a specific region near Birmingham, which is sort of in the middle of England, where when they were going to go into a mental health crisis, and then what we did with it. So the technology really was very good at detecting that crisis, and we have a thing called 111, so 999 is for an emergency, 111 is for not an emergency. And what they found was actually great for diagnosing that that person was about to have a mental health crisis, but we had no capacity to deal with it. So the out of hours were already out of capacity, we didn't have any doctors, but what they did was they then built a computer-aided system behind that to then just lead people in to that particular area. So what they did was they just deployed the voluntary sector, they have a lot of nurses on the ground, But they also gave some apps and some other tools to those populations to say, well, how do we actually create champions in your own cohort to deal with it? So what I think is about, I think to answer your question in a roundabout way, is think about it as an ecosystem, and whilst a platform or a technology can solve one part of it, use the people in lots of different forms, not just doctors and nurses, but all of the society to try and help once you've made that diagnosis.
Yeah. Hello. Hi. I would second that, and it's a great answer. And just share a little bit of my opinion and my experience, because our hospital is one of the 44 Ministry of Health administrated hospitals in China, and then one of the largest of its kind in China as well. So we have the ability to solve the difficult cases and rare cases, as well as covering the network of primary care at the lowest level. And then we do have the AI in our thinking is, one, to use the AI to help certain diseases, not every. They are going to be helpful in our inside the hospital, that kind of work circle, not every part. For example, pathology, because if you do this screening of the big image, one image, pathology image, can take about 3 gigabytes. That's a big one. An experienced doctor, pathologist, will take about 30 minutes to examine everything and make the right diagnosis. But if we have the AI to assist us, to make the automatic annotation, that can speed up to 2 minutes, and without any probably loss of that kind of symptoms or in that image. And then that's in the process. The second part is for the work of early detection. That's outside of the current workforce or the work cycle. Inside the top university, top hospitals of top universities, and then the doctors are well trained. They know how to do the early detection when they see the exam results, and then they see the pictures, or they see the patients. But the outside rural areas, they don't. And for example, dermatologists, they're really rare in rural areas. But if they have the basic educational level dermatology, and then they have the AI-assisted process, then that will leverage the care quality. Then that's going to be useful to promote the accessibility and the equality for care. And I think every country is working on that. And the AI and the big data will be the most important part of it. And then I believe that's going to be the future. That's why we are sitting here. Yeah.
I'd like to differ, though. It's the most important.
Okay, 3 great responses. Yeah, go ahead.
Yes, I fully agree with Dr. Huang's opinion. Actually, it's the situation in China, actually not only in China. AI can help the patients and doctors in hospitals and also out of hospitals. And healthcare is a complicated system. It's not only the front end, the screening part, right? For the back part, the cure and treatment, right? It cannot done only with AI, right? So we are building. I'm in China and in many countries they are building the so-called hierarchical healthcare system. So the first step, AI can help, right, to detect to early identify the patients who in great need of this healthcare, right? Okay.
Fantastic, thank you. Any further questions? Marcel, did you say you have a question? Yeah.
But, I mean,
no, go ahead.
So in your talk, I saw quite clearly in your point 7, right, that you kept mentioning that's pretty much exactly what the focus group is designed to do, sort of help with the benchmarking and the evaluation. So I'd be curious also to hear, first of all, of course, from you, but also from the others, if that type of benchmarking approach that you've heard about this morning, I assume there's a reason also why you're here, but if you see that as a critical piece in your pipeline as well. That's not to ask, is it the most important piece? Because I understand healthcare is complicated. There's many different pieces that need to be in place. But this is what we're planning as sort of outputs of this focus group, something that you would think is actually quite useful, or something where you would say it's nice to have, but that's not currently where the fire is burning for us?
Yeah,
bit of a loaded question, I'm sorry.
That's a great question, Marcel, and that was kind of one of the things that was burning in my mind as well. You know, Indra gave a great example of the complexity of the landscape for just one national commissioning body. So thinking about whether or not this benchmarking would be useful, you know, can you also give us some, I know you've got like a minute, some kind of very brief idea of what the kind of standard for entrance is right now, you know, Yanwu, you mentioned that your research is got CFDA approval pending. You know, what's the kind of, how would benchmarking fit into that? Is there any dovetail there?
That's really a very complicated problem. Actually, the CFDA don't have certain regulation on AI products in China. But FDA works a little bit faster than China, right? They approved 10 AI products. So I think CFDA can follow these examples. So now the validation is done still in hospitals under the clinical experts' supervision. So what is acceptable and what is unacceptable, it depends on the clinical side decision. So in China, we still don't know.
So it's at the discretion of the individual physicians.
Can I make some comments on that? Because I'm on the board of doing that kind of benchmarking, you know, in China, which is led by our Chinese partners, and then CAICT. And then we had the board team, which is coming from the university and the hospitals and the laboratories, and then and also the institute and the CFDA as well. So we had several meetings. I think this is on the way, and then China is considering that seriously. And then we got several dimensions of that benchmarking. One is technical side. Yeah, we only talk about a black box or white box thing from the computing point of view, and then see if that's going to be helpful with the standard data sets. That's nothing to do with the clinical, we say, effectiveness. And second is we have to choose the practical application scenario for benchmarking. First of all, is to determine which kind of diseases will be really pragmatically useful for AI assistance. Yeah. And I think we have private sector, public sector, universities and hospitals, experts, doctors and computer scientists all join on that board. And then we had, broad and then in-depth discussions on that. And I think China is doing that kind of work, and then is eager to really to break through. And then the only thing is it has to be tested with standard data set and also open data set. And then Shanghai Hospital is one of the testing, basis in China. So we are doing that. The third part of that benchmarking is, I think, the content side, which means the data itself has to be validated. And then it takes a lot of work. And then the CFDA did something in the something like lung cancer or the kind of images, and and also the eye images, etc. And then organized group of experts in that field, consultants. Most of them are consultants. Lots of money, long time, and then every case is well examined and well annotated. And then it's a long process. I think some of the work could be shared, and then because they are all anonymized and all clinically validated, but not in every field, especially in dermatology. So it's a long way, and just because AI for health is a buzzword, just like 15 years ago we had the buzzword for mobile health, and then I was in that circle, mobile health, and then we coined that in our group in 2005. And then what happens now is Chinese government is looking into that from the regulational point of view, and also hospitals are kind of cautious because it's practicality. So we select the breakthrough direction carefully for pathology, for the dermatology. Maybe they are well-driven and then well-directed, supervised.
Great. I'm just going to keep it quite brief because conscious of time. But Marcel, I think to answer your question, whilst we're doing quite a lot in regulation for healthcare, we've talked a lot here about clinical diagnosis. Let's not forget operational efficiency. We have something called the Better Regulation Executive, which is across all the regulators, so people like the ICO, our Information Commissioner's Office, who are also setting standards in this space to say benchmarking what does good look like if you are deploying. And we're particularly interested in the public sector, because I think when you're talking about private sector, it's a bit different. But if you are having a machine learning algorithm that's making decisions within the public sector, I think you do need quite a high benchmark. So we do have quite a lot of working on that space. Happy to collaborate with anybody, either drop Naomi or myself, or I'm happy to share that.
Saurabh, do you want to be the last to answer Marcel's question on
as was
benchmarking?
emphasized before, healthcare sector is quite complicated that way because physicians and clinicians want to have that liberty to choose what they want to practice from the evidence which is coming from clinical trials, and so is going to happen with the AI tools which we'll have in a few years down the line. So if we can have a kind of benchmarking which can guide them, some sort of guidelines and best practices, then that is the best part of it, because as such, the medical community from the evidence is getting a lot of confusing inputs. So I think all countries which are working on AI, they are having their policies, and so do we have. Although to reclaim that kind of leading position from the healthcare to guide them will be slightly challenging, at least in our scenario, because the healthcare sector as of now is working on their own autonomously. Like, I don't want to get more and more guidelines coming from the authorities. So something similar may be one of the challenges which we'll face once benchmarking thing comes in.
I don't think we're working on our own, because if you read the reports out there, so like you have the AI Now Institute, who have put out some really good guidelines for the ethical development of AI and AI for good. I mean, there are a lot of regulators and think tanks out there who are thinking about this, and I think healthcare data is just slightly different, but there are universal laws that apply in this space.
Yes, but healthcare is quite different from other industries in AI. So it will be slightly different compared to what we have.
So, Saurabh, are you saying that the doctors like to have a degree of autonomy in their clinical practice, and that they practice
I
according to...
a bit of a challenge kind of thing. As of now, you have, say, guidelines from American Society, European Society, then best practice guidelines, and then the working patterns are quite different from all these guidelines. We know that.
Right. So that's a point around the kind of the evidence for change. It enters clinical practice guidelines, and then the time it takes from guidelines to affect the kind of what individual clinicians do. And so your point, I think, is if we manage to successfully set up the benchmarking, we need to find some way to work within that established flow of information, or ideally to be more successful at influencing clinicians' behavior.
Yes.
Okay.
For successful deployment in healthcare, that gap has to be bridged. So.
Very interesting. Thank you. Yeah, go ahead.
Okay, thank you very much. My name is Hani Iskandar. I work for the ITU and I'm responsible of digital health. So basically, I'm very much involved in working with a lot of countries in deploying digital health, particularly in the developing world. And I would like to echo actually what Wayne said about, the hype around mHealth maybe 10 years ago. And indeed, it has been seen as a sort of a new innovation. But, till today, I mean, many countries around the world are still struggling to adopt and integrate those types of innovation in existing systems. And they are still seen as almost like a ad hoc thing. They are not integrated within the current clinical practices, indeed, and they are not really contributing as such to the strengthening of the health systems. And of course, you can think that AI as a new innovation might go through the same risks of, being an innovation that it's still out of the system, etc. That's why we are very much advising and working with the governments to really think in terms of ecosystem, really thinking in terms not of siloed innovations, but as a whole of sector or a whole of system type of innovations. So the approach of having an ecosystem approach, and thinking in terms of all the different elements is really critical in terms of adopting those types of innovations. And this is still ongoing. So I've been, quite looking at what, you have been doing in NHS, but also in China and India, and I think you had approached this as an ecosystem, but I mean, your ecosystem is very much mature vis-a-vis the other countries. So my question is, if you are to advise developing countries who are still in the early stages of adopting digital health tools about AI for health, what would be your approach? Obviously, the benchmarking is a critical piece, but are there any other things that you think are important for countries to adopt or to try at least to think about? Thank you.
So we've approached it in three ways, is to look at the technology, so create standards, create an ecosystem where it can flourish in a safe way. And to do that is to work collaboratively with both the regulators who regulate this space, both in and outside of health, but also with other industries. So we work closely with, say, the automotive industry or the mobility industry to say, how can we do this together? So create the rules, create the framework to play properly and safely. Then you've got to bring the people along. So you talked about clinicians, and I hold my hand up as a doctor. We're a little bit rigid and think we know best. But so this is why we had the topple reviews. We had an external clinician come in and try and help us understand how we train our workforce. We create digital champions. So it's great for us to sit in this room. We're 50 people. But if you're outside and you're seeing somebody day to day, you need to feel confident with that technology or whatever the innovation might be. It doesn't have to be a tech. And then the third thing that we're doing is we're working with our think tanks to bring patients along. So we had a bit of a scandal a few years ago where patients didn't want to share their data or they didn't really understand what sharing their data meant. But it's to create that, and it's just comms, marketing, engagement, but to bring the population with you. So the three things I would say is tackle is work collaboratively in a regulatory framework, bring your workforce with you, and get your patients or your citizens on board.
Hello. My answer to that question is quite straightforward. With or without digital technologies, we need to get the latest technology, including AI and big data, together with it, alongside our current clinical pathway, clinical workflow. But only when the data and the algorithm is safe enough, it can be integrated. We are running that parallel, and we find ways. I'm doing quite a lot of projects at this moment inside the hospital. And then we have about 16 projects going on in my hospital, and I'm assisting that in about 20 departments. So each one is doing some part of their workflow. But only when my system, my smart care system, is safe enough and robust enough, and then it could be integrated into my current working system, like our EMR system, then I think we have to embrace that. As a computer scientist, I would like to see that. And then I'm telling you, doctors would like to see that. They want the best quality control, from the writing of the EMR history and the records, etc., and then down to the, justification whether the diagnosis is correct or wrong, or pathology takes a long time. Everything. They want that, but they need the proof, which is safe enough. The technology is safe. The system is safe. Then they can integrate that into the current working system. But we don't have to hesitate. Yeah, that's my personal opinion.
My stand is quite straightforward. If you are coming from a developing world, and then you have to have your priorities right. AI for health is a buzzword, so you choose what you work on. Don't just work on what others are working on, because your priorities should be, and they are different from the others. So we have to find some areas where you can give to the world, and there are some areas where you can take from the world. Everywhere we cannot take the lead, but we can supplement others who are working in that area or something similar. Like for example, for India, tuberculosis control is a major challenge. So I think we are going to work a lot on that, and maybe not on some other areas which may not be our priority.
Yes, because Baidu is a big company, so what we are doing must meet the requirement and the regulations from the government. So for us, the first thing we can do is choose the right topic. That means it's not that serious or that can cause very bad or serious results if we make wrong decisions, right? The second one is all the reports we generated from the AI system will be confirmed, double confirmed from the ophthalmologist with our clinical partners. So we still follow the regulations from the government side.
Okay, well, fantastic. I think that was a brilliant... Oh, have we got time for one more question, Bastien? Okay, he says yes.
Thank you very much. I was very pleased to see in the first two presentations a combination not just of AI, but also of building some kind of hardware, some kind of data capture device to be able to make kind of that whole system more intelligent, but also be able to get kind of more data in. I was wondering if anyone in the panel can think, or kind of in your experience, do you have any other sectors or any other applications where you think that by developing some kind of hardware or better data capture device or standardization, there might be very low-hanging fruits where the AI as a software layer kind of can bring in some very quick wins? Because we've seen this a bit like in what Baidu was presenting in terms of the eyes and then the dermatology with the app itself. I was just thinking if there are any other applications which are low-hanging fruits. Thank you.
Okay, panel, I'm going to press you to keep this brief in one line before our audience go faint with hunger. So go ahead.
Yeah.
Very brief.
So I mentioned in one of my slides, in cardiology, ECG interpretation for complex rhythm is something which is quite complex, and there are only few experts. Even in the developed world, you have centers where there is specialized people who are working on this. So this is something where AI can be actually good, because this is just, again, image analysis sort of thing, which involves a lot of already established clinical algorithms where it can be used.
For us, actually currently we only have one medical image analysis product. This is for the hospital environment. This is for screening only, so it's just for the effectiveness and the cost, which is not that serious, I think.
Okay.
I just named several I'm doing, and then if you are interested, we can go offline. And then after surgery, we have the skin flap. Yeah. And then chronic wound management, and then lung cancer detection, and then pathology, and name a few, and then integrate medical and social care for aging, AD, and etc. and PD. Yeah, name a few.
So if you were to think outside of it, I think people like to think AI for health means clinical diagnosis. So some of the stuff we're doing in the UK is we're looking at blood transport, predicting plasma, predicting blood flows. That's really difficult. Machine reading, you and I reading a barcode, prone to error, machine reads it, error is reduced, so life saved. The second thing we're doing is looking at hospital flows, so looking at bed flow, predicting where staff will be needed in the ward. Again, low-hanging fruit. You can do that with the data if you collect it in your hospital quite easily. And the third thing is what we all love, chatbots. So using chatbots in various areas. So we're using it in triage, we're using it in mental health for children, but also to help children navigate their way through a hospital when they're having an operation. So we've got something called the Olibot, but we've also got other examples.
One last sentence. The most challenging thing to computer scientists like me and him is NLP, natural language processing. And that could be extended,
Forever.
very, very long. So we don't talk about that, but that's the most challenging thing.
I'm going to leave you to discuss that one over lunch. So thank you to the audience. Thanks for hanging on, and thanks to the fantastic panel, Indra, Wei Hung, Yang Wu, and Sarah. Thank you so much. We're going to break for lunch, Marcel. It looks like you want to say something about the logistics.
Right.
Thank
so
you.
I have two points to make. Is this on? Yeah, this is on. So the first is we're going to take a group.